Ladies and gentlemen, members of council, you'll notice that my title slide has a background picture of Seattle, Washington, which is where I live. No lecture at this moment would be appropriate to start without mentioning that last Sunday, Seattle became the champions of the world in North American football by winning the Super Bowl. To show you what this small event meant to my community, the population of Washington State, which is where Seattle resides, is 6 million people. They had a parade for the team down 4th Avenue in Seattle on Wednesday, and it was attended by 750,000 people. So I think people in Seattle think this is a big deal. I'm also going to say that in my breast pocket there are 2 tickets to a small sporting event that is occurring tomorrow in Dublin. It is going to be my intention to bring what we call the 12th man magic to your sports stadium tomorrow, because I would like Ireland to do to Wales what Seattle did to Denver, which was kick them all over the field. When it comes down to the aspect of being given an opportunity or an honor, I think that there's no better place to start than to look at the people who have preceded you. This is by no means an indication of all the people who have given the Colles Lecture, but these are a grouping that are in my area of particular interest: thoracic, general surgery, and upper GI surgery. It is profoundly humbling to look at this list. This is a signature honor in my career, and for that I am extremely grateful to the college. I will also point out that there are 2 very close Irish friends on this particular group. Professor Hennessy was the person who invited me first to Ireland to give a lecture in 1989, and I have many, many friends in surgery, but very few of them were closer than Jerry O'Sullivan. So from that standpoint, thank you very much. I'm going to start out with the good news regarding cancer in the United States. And the good news is we're making some progress. If you look at the aspect of this publication in 2010, you can see that the aspect of cancer deaths per 100,000 in the United States has improved in men 21% and in women 12% between 1970 and 2006. Now, there is some areas of problem. Liver cancer in both men and women, and in esophagus and melanoma in men, they continue to increase over time in spite of the progress in other areas. Now, as you would expect with respect to 5-year survival rates, overall melanoma, breast, prostate, and colon between 70s and 2007 have showed impressive improvement overall in 5-year survival rates. But there are some outliers, and the outliers really are centered in my subspecialty of thoracic surgery. Lung cancer has shown some improvement, esophageal cancer some improvement, but really nowhere near where we want to be or should be with respect to these 2 particular diseases. In addition, even though there's good news, there is problems on the horizon. This is from the Institute of Medicine, and this highlights the aspect of the United States faces a crisis in cancer care because of an aging population, rising costs, and complexity of care, and this is a plea for a shift to more patient-centered, evidence-based care. I'm going to highlight the fact that this particular report from the Institute of Medicine was sponsored by every major oncologic society in the country and every major surgical society in the country, demonstrating the degree of support for this. And this is a very thick report. It covers all sorts of issues, but one of the things they highlighted is the fact that in 2004 in the United States, cancer care absorbed $72 billion. In 2010, it had increased to $125 billion, and it's scheduled in 2020 to be $173 billion, which is a 250% increase. I'm going to point out that $173 billion would make it the GDP, make it the highest GDP of all but 10 countries in the world, and this is just for cancer care within medicine. So clearly, we have issues. The demographics of esophageal cancer has changed too. Historically, we have these visions of older, rather thin, sallow men who've heavy drinkers, heavy smokers. That's true, but the demographics have changed as well. This is a publication from my institution showing a lady who at this present time is 37 years of age. She presented at the age of 32. She has 4 children with a T3N1 EG junction cancer. And she was put on the front of this magazine because she's a 5-year survival of treatment, but this is a demographic that 20 years ago we didn't think really existed. So What is our topic today? Our topic is how do we measure outcomes, how do we grade quality, and how do we impact process? Well, let's start by talking about what are the quality measures that we've historically collected. And here they're listed for all to see. Most of them are well known to you. There are certain ones that we record routinely and in a very straightforward way. There's others regarding costs and patient satisfaction in which we really haven't got our hands around today, but I am going to review some of the issues that we can confront in the future. But I am going to shape this lecture around 4 questions. There is actually about 25 issues that we could talk about today, but I'm going to concentrate on 4 key questions that I think will solidify some of the issues that I think are going to be important in the years ahead. The first question is we cannot improve outcomes unless we can analyze our results. Are we currently measuring our key outcome parameters accurately? And let's start with something easy. Surely, with respect to the number of people who die directly related to the operations we do, we can record this in a straightforward, sensical, and accurate way. Well, is that right? Well, it depends on where you look. If you look at a subspecialty database such as the STS database, it's 3.2% in the United States. Over the same era, if you look at the NISQIP, which is a voluntary database run by the American College, it's a little bit different. And if you look at the National Inpatient Sample, which is a sample across the United States, it's different once again. And all of those were taken during the same time period. However, let's go to another administrative database. For example, the SEER database. The SEER database in the United States is the one we use for Medicare. Medicare is the people over 65. This is the target area for esophageal cancer, and this is a publication by a very famous physician who's been looking at major cancer care for some time, outlining that in esophageal cancer, the number of esophagectomies done between 1999 and 2008 has stayed amazingly constant. The number of hospitals delivering this service has gone down a little, but the overall median number of resections in those hospitals is really depressingly small. More importantly, however, this same paper highlighted, and this is once again 2008, this is not 10 years ago, this is contemporary, that in the United States, in the SEER population over 65, 9% of people are currently expected to die directly related to their esophageal resection, 30% higher than the next cancer operation, which is pancreatic duodenectomy. Is that unacceptable? It's unacceptable. We've had this issue regarding volume and outcome, especially with respect to mortality. We did a meta-analysis that we published in 2012 that tried to put some real credibility into the overall picture of all the literature available. We looked at a total of 9 individual trials, almost 28,000 patients, and superficially, when you look at this data, it seems to affirm the aspect that volume and mortality are directly linked. If you look at the aspect of 30-day mortality and in-hospital mortality, there's an increase between high and low volume centers of a factor of 3 between the mortality rates. However, let's put that aside. Let's look across the horizontal axis. Let's look at the difference between 30 and in-hospital mortality with respect to esophageal resection. At high volume centers, 0.7%, in-hospital mortality, 2.8%. Low volume centers, 2% up to 8.5%. What does this indicate? This indicates that any administrative or general database that is reporting only 30-day mortality is underrepresenting the true mortality associated with esophageal resection. So consider what you're looking at and what the parameters are for measurement before you accept this type of data. And this is the most contemporary piece of data I'm going to show you today. This was presented 10 days ago at the Society of Thoracic Surgery meeting. This once again looked at the SEER database and looked at the difference between 30-day and 90-day mortality in the United States. This is contemporary data up to 2012. 30-day mortality, 9.8%. 90-day mortality, 15.8%. As a medical fraternity and as a country, we should be ashamed, because this indicates that not only is our mortality rate unacceptably high, but we have almost 5% of people that are dying after they're discharged from hospital, but before 90 days. So there is an undercurrent of accuracy in the reporting of mortality that is underappreciated, and we should all be taking this into account. So with respect to perioperative mortality, do we have it right? Well, it depends on where you look and what you're measuring. So what's the next issue we're going to look at? Well, let's take complications for a second. And let's first ask ourselves, Are complications important? Virtually everyone attempts to report it. Well, here's a compendium of publications demonstrating that complications affect almost every other outcome parameter we look at: mortality, length of stay, cost, quality of life, cancer recurrence, and survivorship. And this is one of the best examples of an assessment of the true effect on complications on global quality of life at 6 months. And when you look in multivariate analysis at what the important factors are, none of the surgical factors, none of the things that we do really affects quality of life after an esophageal resection. But what does affect quality of life? Virtually everyone is a complication: anastomotic leak, cardiopulmonary complications, and operative technical complications. So is the accuracy with which we are recording our complications associated with any cancer surgery, let alone esophageal resection, important? Well, without question. And this is an example of the aspect of how it affects costs. This is our publication from 2006, which looked at the aspects of the cost of the delivery of all the standard approaches to esophageal cancer at that time and at the present time. We looked at surgery alone, chemotherapy and surgery, chemoradiotherapy and surgery, and chemoradiotherapy alone. What we found is that when any of these treatments are associated with complications, the cost of delivering treatment increases between 25 and 46%. So complications, they affect outcomes and they affect costs. However, how are we reporting complications at the present time? Well, this is a publication from Lee Swanstrom. He's a well-known minimally invasive surgeon from the United States. What he was trying to do at the time was really compare open and minimally invasive esophageal resection. And in fact, that's what he accomplished. All you notice that even when it comes to chylothorax and arrhythmia, a lot of these high-volume centers did not make any attempt to report their individual outcomes. But with respect to overall morbidity, only half of these papers at that time made any attempt to report what their overall morbidity was with esophagectomy, even though this was a comparative series. And this particular publication, which came out in 2012, and I would recommend this to you because it's from Jane Blaisby's unit in the UK, is a huge systematic review of over 57,000 esophageal resections, looking at what they called outcomes, but virtually 9/10 of the paper focuses on complications. And what they identified is no single complication with respect to esophageal resection was reported in all papers. 61% had no measurement criteria. Anastomotic leak was the most commonly reported complication in 80%, but there were 22 different definitions of anastomotic leak in these papers, and the in-hospital mortality had 6 different interpretations. So irrespective of what you think about comparing results at the present time, we don't have the tools. So the current realities of assessing outcomes with respect to the surgical treatment of esophageal resection has 2 realities. First is that complications are the single greatest factor increasing resource utilization and costs of the treatment of esophageal cancer, but the extent of this effect is currently incompletely understood. The second is that there is no currently standardized approach to the documenting of complications associated with esophageal resection. So I will take a moment and I will introduce you to an effort that's been going on the last 3 years, the Esophageal Complications Consensus Group. This particular group is composed of 21 international surgeons, all from high-volume units and all from units that have a professed interest with respect to the outcome of esophageal cancer. You will notice that Ireland is outstandingly represented by Professor Reynolds, but all of these particular units are recognized in their own countries as being centers of excellence. In addition, this particular effort to document and standardize how we're reporting our results is currently sponsored by OGIS, the European Society of Thoracic Surgery, the ISDE, OZO, the Society of Thoracic Surgeons, and the SSAT from DDW. When I say sponsored, I mean that they think this is a laudable effort. They haven't given us any money. Now, just to show you how big the problem is, the average number of esophageal resections in the database of our members is 950. So these particular individuals have a major commitment to documenting their results regarding esophageal resectional outcomes. And the first thing I did was ask to send in your data sets. Show me what you're collecting regarding complications. And this is a group of 10 from the data sets, and you can see even in these high volume centers, one center at the time was reporting 1 GI complication, anastomotic leak without a definition. This center here was reporting 20 individual parameters. So how do those centers compare? The answer is they don't. So What have we done so far? We've produced a basic data set regarding a list of complications. We don't mean to infer that this is every complication that can happen with esophageal resection, but it's a basic data set that will be a component of the collection of data in all centers. The second component is we've linked it to basic definitions, especially with respect to pneumonia and sepsis, and we've also accepted the NISQIP aspect that all complication and adverse events should be collected within 30 days or in the in-hospital stay of the patient. In addition to the standard data set, however, we've identified that there are certain quality parameters that must be collected as a routine so that we can start to assess not only how we're doing with complications, but with other important operative parameters. There's recommendations for the recording of mortality, who should be entering data, comorbidity assessment, blood product utilization, recording of change of operative, post-operative level of care, recording of complication severity, readmissions, and discharge locations. These are going to be the quality measures of the future. Unless we know this data, we will not really know how we're doing. So, perioperative complications, can we accurately document and compare? Easy answer, no. But in the future, we hope to fix that. Question 2, how does our treatment need to evolve to improve outcomes and respond to demographic and technical changes that are occurring? Well, let's start with 3 fairly simple issues. I know that there's no controversy regarding the centralization of hospital or cancer care in Ireland at the present time, but I'm going to give you some data from the United States that might make you feel a bit better. I'm going to mention the aspect of multidisciplinary tumor board and the changing demographics of esophageal cancer. I was the invited lecturer at the Society of Thoracic Surgeons that was just 2 weeks ago. I was asked to present a case to advocate for the centralization of high-risk cancer surgery in the United States. I will tell you that the United States is the land of the free and the home of the brave. The aspect of centralization of cancer care is not really on their program. So I was expecting an interesting reception. But I will tell you that this centralization process is not just what we're looking at, is the public has got a hold of this as well. This is a newspaper, it happens to be from the UK, indicating that super hospitals for heart and cancer can save thousands of lives per year. And this is the same thing that is appearing in the American press. I'll point out that the aspect of centralization is nothing new outside the United States. Many of you heard of Eureka. Bill Allam from the Marsden is the head of the upper GI unit. These are the countries that already have centralized cancer systems. With what I've heard today, I think we should move Ireland into this already centralized group. The planned group is here, the collaborative groups are here, but the United States remains the elephant in the room. So the aspect of the study that we did was to carry out a comparison of perioperative mortality for esophagectomy between the United Kingdom, which has had a centralized system for cancer care initiated in 2001, and the US that has a non-centralized system. We used 2 data sets to compare. One was the HES, which is the Hospital Episode Statistics, that produces an administrative data set of almost 100% of esophageal resections in the UK. We also used the national inpatient sample that, even though it's 20% stratified, it provides the best indication of delivery of service across the United States rather than in separated or specialty databases. We're not going to go through this whole data, but I am going to show you a couple of highlights. The data set in all cases between the UK and the United States involved 7,400 resections in England versus 58 resections in the USA. Those number of resections over the 5-year period of the study were done in 75 institutions. That number of resections in the United States was done in 775 institutions in the United States. Now think about that for a second. This is a 20% stratification. If there's 775 in this group, how many actual hospitals are doing individual esophageal resections in the United States? Well, the answer is too many. So if you look at the aspect of the second study group we looked at, we then took the upper quartile of the high volume units in the UK, and we extrapolated that to the high volume units in the United States, which gave us a secondary data set of 2,000 resections in England for a total of 8 institutions, and 1,000 resections in the US for 13 institutions. We then looked at results regarding mortality. And if you look at the aspect of the whole data set, the mortality rate in England was 4.2%, which was statistically significantly less than what it was in the United States at 5.5%. But the really interesting data was the second component. When you went to high volume units in the United States, the high volume units in the United States had an overall mortality rate that was half that in England. Now, I will tell you, this got their attention because most of the people in the STS profess to come from high volume units, and this is the type of data the United States is going to need to start the same process you've initiated in the US, because right now the aspect of distribution of services is far too big. So what are the other issues that go along with centralization? Well, if you ask the American Cancer Society, they will tell you that patients in the United States are much more likely to be presented at a multidisciplinary tumor board if you're in a centralized system than if you're not. Does that matter? Well, these are the demonstrated advantages of a patient who with cancer is presented at an MTB. And there's all of these, I think, are well proven. In the United States, the decreases of potential bias and, unfortunately, profit is a big issue regarding MTB presentation. But the increase in patient satisfaction has been underappreciated. At our Virginia Mason Thoracic Tumor Board, these are the subspecialties that are represented on our weekly tumor board. In 2012, we presented 510 patients, 240 index esophageal cancer cases. And we've done a study to see how often thoracic tumor board actually affects the aspect of the individual management, even at our, quote, high volume center. And this was a prospective observational study. Providers, these were the managing doctors, submitting the patients were asked to give their pre-tumor board treatment plan. We then reviewed that and compared it to the tumor board recommendations, and we did this for esophageal and for lung cancer. And if you look at the aspects of minor, moderate, and major changes, and those major changes when we changed the whole theory of treatment. So we went from surgery to hospice. We went from chemotherapy to surgery. Those were major changes. It occurred in over 20% of cases. So our MTD, even at our, quote, high volume center, changes the theory and the theme of treatment in over 20%. And interestingly, it was even higher in lung cancer. In addition, we followed these patients up. How often were the MTB recommendations followed? Well, I'm actually proud to be able to show to you that in 98% in my institution, the MTB recommendations were followed. So is this an important adjunct to good cancer care? Without question. And when it comes to demographics, everyone in the audience knows that the incidence of adenocarcinoma is increasing exponentially. In fact, in the Western world, adenocarcinoma has increased 400% in the last 20 years. But where is the big increase? It's in men and in older men. And what's happening with respect to our population demographics? The percentage of people over 65 in the United States and in fact everywhere else is going up and projected to be actually almost 55 million of the total population of 300 million by 2020. What does this mean? It means we're all going to see more people with esophageal cancer, and they're going to be more advanced in age. So we must be ready for this, and we must have a system that is facilitated and able to deal with this changing demographic. And we started to look at this several years ago. We published this last year, a systematic review of the outcomes with respect to esophageal resection in patients with quote-unquote elderly age. And what we found did not surprise us. The publication demonstrated that in people over the age of 70, there was an increase in in-hospital mortality, cardiac and pulmonary complications, and a decrease in 5-year and cancer-free survivorship. I'm also going to show you a publication that came out in 2006. This is from a little-known cancer facility called Memorial Sloan Kettering. They have a reputation for high-level cancer care, and they examined their cohort of people who were over 80 years of age, compared them to a much larger group with respect to outcomes. They demonstrated that when you were over 80, your mortality rate was almost, this is at Memorial, by the way, the mortality is almost 20%, and your length of stay is 26 days. Now, if you were younger than 80, your mortality rate was 5.8%, and your length of stay was 16.4 days in the same time period. I'm not sure I'm happy with either of those outcomes. I think that both of those are stratified wrong, and quite frankly, at Virginia Mason, we don't think we're seeing the same types of outcomes. So we reviewed our own data. And we published this in the Annals of Surgical Oncology last year, and we made the title exactly what we wanted to say, that it's physiology, not chronology, that dictates outcomes after esophagectomy for esophageal cancer in patients 80 years of age and older. And what we found is, once again, not surprising. When you look at standard outcomes like complications, Total morbidity, it's higher in the people over 80. And that has most to do with the aspect of arrhythmia and with the incidence of pneumonia. But let's go to the really important outcome measures. And when it comes to that, in-hospital and 30-day mortality, there was no difference in the less than 80 than in the over 80. And in fact, we had no mortalities in the 32 patients who were over 80. In addition, 2-year and 5-year survivorship, exactly the same. So from now on, when the aspect of age comes up, I think that we should have criteria that bases the issues on physiologic health and not chronologic age. We see people in their 80s who are much healthier and have better quality of life than people in their 50s. And the aspect of how we choose who to treat should not really be based on how many years they've been on the planet. So, third question, and those who know me in the audience will know that this is the one that may be closest to my own heart. Are outcomes more about the provider or more about the process? Well, let's start from the aspect of how many ways are there to take the esophagus out? And the answer is, it's becoming increasingly large all the time. And with respect to the advent of minimally invasive surgery, which we've had beautifully presented throughout this conference, the one aspect you can say about the introduction of minimally invasive surgery, and this is from the UK, is that it's been done very responsibly. The aspect of outcomes are good. We're doing good cancer operations, and overall, it's going to be a major player down the road. However, what have we as surgeons done historically? We have spent our entire life trying to convince other surgeons that there's a best methodology for removing the esophagus. Now, in certain hands, that may be true, but the aspect of how we do an operation should vary on the basis of the physiologic health of the patient and the tumor presentation of the cancer. And these are all well-known people who will stand up and continually tell you that there's the best way to take the esophagus out. Now, if you don't think this is contemporary, this is from May of last year at the AATS meeting in the United States. I was asked to join a debate with 4 other little-known people, Mark Oranger, Tom Rice, Nasser Al-Turki, and Jim Lukatich. And we were each given a methodology of esophageal resection and asked, would you please tell the audience why this is the best methodology? And I must admit, I disappointed my thoracic surgical colleagues because I spent 3 minutes on my 15 minutes talking about the recognized advantages of the Ivor Lewis in a focused operation. I spent the rest of the 12 minutes telling people how this debate was no longer applicable, in my mind, to the general delivery of surgical service to the esophagus. I will give you a vignette about that. I have never received more emails after a talk in my entire life. I received over 100 emails, of which 95% were positive, that they said they finally were interested, that someone had the guts to stand up and said that there was more than one way to skin a cat. And I believe that this is one of the process issues that we all have to come to grips with. This is the overall approach that we use at Virginia Mason. You can see that there's criteria for which we use various approaches, and we apply this according to individual patients. However, what are the individual factors that we can do to significantly improve outcomes of esophageal resection? Well, surgeons have historically concentrated on technical and surgical issues. It's not a surprise when assessing outcomes and quality parameters. Concentration of cancer services, we've already reviewed, has increased the likelihood that complex cancer operations will occur in high-volume centers. Let's accept for 1 minute that the maintenance of high-quality technical operations is critical to produce good outcomes. Let's just put that aside, and let's just say we all do good surgery. The greatest opportunity for improvement resides in refining the processes of total service delivery best expressed with respect to the application of standardized process or enhanced recovery. Almost everyone in the audience has seen this. It is absolutely the pro forma for what we should be considering regarding complex delivery of surgical services, let alone cancer care. And occasionally we get sidetracked. Rob Cerfolio is a good friend of mine. Fast tracking is a good concept, but it really is too focused. The aspect of fast tracking is all about the operation in the immediate post-operative period. The standard process has to be more complex and more all-inclusive. This is a paper that we published in 2007. This was given the award for the best paper of 2007 at DDW, I think for a variety of reasons, but one of the reasons is that we were the first to stand up and said our responsibility for surgeons is to assess what we do from the moment of referral to at least 3 years after we have done the operation. And the whole aspect of that delivery system has got to be orchestrated, because the operation is a key issue, but it's one of many issues. These are the people who go into the aspect of the forming of our standardized pathway. It involves every single stakeholder that touches the patient at any time in their journey. This pathway was formally initiated, although we were applying it in an organized form before this in '98, and it's undergone 5 formal modifications since its initiation. This is the current format, which affects every single thing that goes on with the patient from the time of referral to the long-term follow-up, with quality measures along the bottom that we assess every 6 months. What's happened to our patient population since the initiation of this pathway? Well, if you look at these 600 consecutive resections, our mean age has gone up, our BMI has increased, our comorbidity indices is increasing, and our incidence of diabetes, clinical stage 3 disease, and neoadjuvant chemoradiotherapy are all significantly increasing. And what else is going on? Well, during the same period, our operative blood loss has gone down. Our utilization of intraoperative fluids has significantly decreased. Our ICU stay has gone from 2 now to 1, and in fact, in the last 2 years, we use a step-down unit. Our hospital stay has gone from 10 to 8 days, and our mortality rate over this long period has stayed at what we are proud to say is a reasonably small degree. Now, with respect to the implementation of these pathways, who is the key issue? Well, it's not me. This is Sonia. Sonia is our thoracic oncology nurse coordinator. She is the person. I saw a wheel with a spokes coming into the middle in one of the talks today. Well, she's in the middle of our wheel, because she's the one that really coordinates care. And she's the one from the moment of the referral that starts the process going that has really changed things. So what does she do? Within the time of receiving a referral in the thoracic unit, within 48 hours, she calls a patient and makes an appointment to speak to them and their family over the telephone. She reviews all of these issues: past medical history, current symptoms, current investigations, travel arrangements to Seattle, and an initial description of her treatment and surgery at Virginia Mason. This interview takes anywhere from an hour and a half to 2 hours. And I'm going to come back to that at the end of my talk and demonstrate how important it is. In addition, there's a commitment within the pathway that after their workup is complete, we will present them at Thoracic Tumor Board within 7 days, and we will get back to both the patient and the referring doctor within 24 hours. And that was, once again, all Sonia. Sonia sends this out to every patient before they come to our hospital. We have a commitment for their entire physiologic and entire staging workup happening within 2 days, and you can see the number of investigations and consultation that goes into that assessment. If you know why this is important, well, some of you have seen this slide. This is in a group of patients in my series of 415, indicating that over 50% of my practice comes from outside 150 miles, and 26% comes from outside 400 miles. So there's people coming a long way for this workup and this surgery, and the orchestration of their visit is a key issue to making sure that we use their time effectively. Now, when it comes to the aspect of how we achieve goals within the pathway, there are 40 things I could talk about, but I'm only going to talk about one today. This is our current goals regarding mobilization of the patient immediately following esophageal resection. I saw a picture today of a lady who was walking 6 hours within a minimally invasive operation in Ireland. And I'll tell you, it warmed my heart. Because the bottom line is that too long, in the United States, at this moment, 50% of the resections are still ventilated at least one night after surgery. But what's our goal? Our goal is to, within 4 to 6 hours of surgery, to have the patient sitting in a chair, walking in the hall at 12 hours, 6 to 8 walks of greater than 200 feet by postoperative day 2, and independent mobility by day 4. That means they can get out of bed and move without any assistance. This is an example. This is a gentleman. He's 4 hours after an open Ivor Lewis esophageal resection. This was about 8 or 9 months ago. These are not VM employees. This is the head thoracic or upper GI anesthesiologist from the major cancer hospital in Liverpool. This is the head ITU nurse. They were both visiting us there watching our process. They missed this gentleman's first walk because they were actually having their dinner after we finished the resection. This is his second walk within 4 hours of surgery. This gentleman went home on postoperative day 5, and the ITU nurse said to me at the end of all this, she says, you know, Dr. Low, we do have a lot to learn because our average stay in our ITU is actually over 5 days. And here's a situation where you are able to get people home in 5. But it's not me. And that is the message. The The message, it's the process. It's the entire aspect of what goes on at VM. And if you look at how often we achieve our goals, this is from the 2007 paper, but if you bring it up to the mobilization of what we're capable of doing between 2009 and 2012, we achieved that first day mobilization. That's a day of surgery in 72%, and on post-operative day, 92%. So we are achieving goals within our pathway pretty well. The other aspect of having a pathway is that you have to have set goals within the pathway. And the only way that you can find out why you're not achieving your goals is to have data. And therefore, along with a pathway, you must have a database. And I'm going to show you 2 examples of how you can identify problems of not achieving goals and confront them. And let's start with complications. In 2009, we recognized we weren't achieving our mobilization goals or our discharge targets in a significant group of patients. When we analyzed our complications, to our surprise, our 3rd most common complication was delirium. Delirium is not typically assessed. It's not typically acknowledged as a complication. It is increasing importance as the population ages, and it's more likely to occur with respect to major cancer surgery. So what did we do? Having identified this, we started analyzing patients with a mini mental state examination, which identifies people at risk for delirium. We monitor them in hospital with a confusion assessment method. We then were able to identify patients at risk, and we introduced preventative maneuvers in that population. And between 2009 and 2012, the incidence of delirium went from 9 to 2%. Now, along the same pathway, that's with respect to outcomes. What about process? Well, one of the big issues we came into grips with was we couldn't get patients transferred out of our step-down unit to the ward within 12 hours. So we initiated a rapid process improvement workshop at Virginia Mason. We involved surgical management, nursing, bed control trainees in our Kaizen production office. The outcome was we developed standard work for thoracic ward and bed control that changed our success rate of making that transfer within 12 hours from 62 to 97%, and that change happened over 4 months. So the aspect of having data and the infrastructure for review are what accomplishes goals, and that is now standard work for nursing in our hospital that came out of that RPIW. We also don't use the same parameters when we quote outcomes. Length of stay, we've already heard from Professor Reynolds earlier, is not a very good surrogate for outcomes. And in fact, I agree. But when it comes to the aspect of fast tracking, ERAS, and overall costs, it is one of the things that people look at to extrapolate results. And historically, what have we done? We've talked about length of stay as a mean or a median result. Well, in fact, we still record that sort of thing, but we don't look on it in the same way in our institution. What we do is we look at the percentage of patients that we achieve our pathway targeted goal for discharge. So in this era between June and April of 2012 and 2013, these are 35 resections, and these are the 6 patients were discharged in 5, 7 and 6, and 9 and 7 days. That's our discharge goal. So we are currently at a success rate of 63%, which we can monitor. So there's always going to be outliers. These outliers are going to skew your mean, and it's going to make your median more difficult to interpret. But the aspect of using your pathway to dictate how you report and assess your results, I think is going to become more important. Now, the question that you might ask is, okay, fine, I hear about Virginia Mason. Apparently you're doing a good job, but is it extrapolable to anywhere else? Well, these are the groups, and I mean groups. These are not surgeons. These are entire groups that have visited Virginia Mason, up to 9 people at a time at their own cost, just to spend some time and watch at our pathways. And when it comes to the aspect of reporting outcomes, Sean Preston, who works in Guildford, which is just south of London, he was in one of the first groups. He brought 6 members of his team. He went back to the UK, and he initiated our pathway in many of its components over a year in his hospital. Then he took the next year, and he analyzed the changes in outcome between the time before the pathway was initiated and after the pathway was initiated. And here are the results. In the pre-pathway era, he was mobilizing people on the first day after surgery in 8.3% of the time. His complication rate was 67%. His ICU stay was 4 days, and his hospital stay was 17 days. 12 months after initiating the pathway, He was mobilizing people 100% of the time on the day after surgery. His complication rate had gone from 67 to 25%, his ICU stay from 4 to 3 days, and his hospital stay had gone from 17 to 7 days. And if you don't think this got the attention of his health authority, you're wrong. Because all of a sudden he had this data and he was able to talk to them about new resources for his cancer program, which, although he didn't get everything he wanted, he actually had a bargaining chip which made things differently over time. Now, this same process has allowed us to produce standard work for anesthesia, the aspect of a nutritional algorithm that is part of our MTB, the aspect of a patient journey that is based on our pathway, and an algorithm for the management of early cancer and Barrett's. So the spin-offs from the standardized esophagectomy pathway can be extensive and can be a component of your overall care. What's the final question? And it actually is potentially the most interesting. We know what we analyze, and we know what we monitor, and we know what we think is important. But what do the patients care about regarding the outcomes of major cancer surgery? Well, let's take you back to that paper from the Institute of Medicine that I mentioned right at the beginning. Remember the system in crisis? It had 3 pages of conclusions, but they had 2 that they felt were central. And one of them was that cancer care in the United States is often not as patient-centered, accessible, coordinated, or evidence-based as it could be. And that's a statement that I agree with very strongly. We tend to gravitate toward measuring quality of life, and that's completely understandable. This is our publication from 2006 demonstrating that an aspect of 5-year follow-up, quality of life compared to the general population is back to a baseline, and this particular measurement has been validated with many other studies, as you can see here. However, when it comes to patient satisfaction, there is a methodology of measuring it. And if you talk to Clifford Coe, who's head of quality for the American College of Surgeons, he'll tell you that patient satisfaction is increasingly important, but almost nobody is looking at it. Historically, when it comes to programmatic success, the aspect of it's all been focused on the surgeon or physician leader. We have made all the decisions, and in fact, we've taken all the credit. Data from patient satisfaction surveys indicates that the success from the patient standpoint is directly associated with good communication and setting and achieving specific patient-oriented goals. So what does that translate? Well, what do we expect to do with the patient as soon as we get the referral? You've already heard. We expect to contact the patient, interview them. We have pre-treatment staging within 48 hours. We present immediately at Thoracic Tumor Board, and we get back to them within 24 hours. What does the patient expect when they're admitted to Virginia Mason for their esophageal resection? They expect to have an epidural, they expect to have a feeding tube, and they expect, irrespective of what they've read on the internet, to be out of bed on the day of surgery. They expect a discharge date of 6 or 7 days, even though the average length of stay in the United States is about 15 days. They expect a restricted diet. They expect to stay in Seattle after discharge if they live outside 50 miles. And they expect to take part in research, because this has all gone over with them before they come in for their esophageal resection. But here's the point that you might find particularly interesting. We've been measuring patient satisfaction for the last 12 years. And what is the #1 issue that patients point out with respect to their care at Virginia Mason virtually at every year that we assess this? It's the phone call that they receive from the cancer coordinator immediately following their referral. That's the #1 issue, not the surgery they have, not the outcomes they expect, not the aspect of the team, not the issues of anyone they've met, not the overall quality of the care, but the fact that someone cared enough to pick up the telephone when they'd just been told that they had esophageal cancer and spend 2 hours of their life telling them what it meant. And this to us is an expression of the fact of somewhere where we can do a lot better. And I'm sorry, the second component that they highlight is the impression that their care was given by a team that communicates and has established system for treatment delivery. So here's the real surprising thing that Clifford Coe will tell you, and in fact, Jane Blaseby. Patient satisfaction with hospital care is independent of morbidity, treatment type, and quality of life. And if that's not a surprise to you, it certainly was a surprise to me. Now, we've talked a little bit about patient satisfaction. Let's talk for just 1 second about surgeon satisfaction. Sonia has a habit of telling people that she wants to keep in touch, so they write us all the time. And as a result, we've had people communicating with us for, well, over 20 years. And this is a gentleman, and this is a collage of the pictures he's sent to us over the years, and this is the Christmas card he just sent me this December. I'll read it for you. It says, "Thank you again, Dr. Low, for another good year of living pain-free and doing most everything. Never thought I'd reach 80 after major surgery back in 1992. You and the Lord did great." Well, when it comes to surgeon satisfaction, any time that you're included in the same sentence with the Lord, that is profoundly satisfying to virtually everyone. So with respect to summary, what are the issues that I'd like you to take away today and to think about, although I have a suspicion that this audience is already well acquainted with many of these concepts? Our current methodology for recording outcome is routinely inaccurate. The system for recording outcome parameters for major cancer surgery needs to be standardized. Centralization to high-volume centers or centers of excellence will facilitate better application of evidence-based treatment and improve results in an aging population. Enhanced recovery programs and standardized clinical pathways provide an infrastructure to improve multidisciplinary treatment and process. Avoiding complications and mortality related to major cancer surgery is critical, but surgeons must evolve to better understand the broad spectrum of issues which contribute to patient satisfaction. I will tell you a story that I did my thoracic training for 2 years in the UK. I did my cardiac component of my thoracic training in Birmingham. When I arrived in Birmingham, even though I was going to do cardiac surgery, I met with the head of GI at the Birmingham hospital I worked at, which at that point was East Birmingham Hospital. And I said, "Listen, my real love is esophageal cancer, and I'm perfectly happy to get involved in any of your patients that you would choose to have a surgeon involved in." And he looked at me with a somewhat quizzled look, and he said, "My boy, when it comes to the treatment of esophageal cancer, you can do more with a bottle of whiskey than anything the medical establishment currently has to offer." I did believe that that was a little nihilistic at the time. I think it's definitely nihilistic at the present time, and I think we're doing a better job, but we can do this job so much better. And I'm going to tell you one other additional story. I am the current president of our regional surgical society in the Northwest called the Seattle Surgical Society. The outgoing president is a gentleman named Professor Carlos Pellegrini, who has another inconsequential job in that he's currently president of the American College of Surgeons. I was meeting with him in January because we were talking about the evolution of the Seattle Surgical. And he told me that he'd heard from my secretary that I was doing quite a lot of traveling early in the year, and he asked me what I was up to. So I told him where I was going, and I obviously told him I was coming to Dublin, and that I was given an honorary fellowship. Well, he reached across his desk, and he took down his professional card. And he highlighted to me that the current president of the American College in the United States of America only has 2 things with respect to his professional credentials on his professional card. One is his fellowship at the American College, and the other is his honorary fellowship in the Royal College of Ireland. So I will end by telling you that Carlos Pellegrini and I have 3 things in common. One is we have a love of the esophagus. 2, we are married to the best people we have ever met. And 3 is that we both are humbled and honored to be honorary members of this college. So thank you very much.